We have three panelists with us. They have a wealth of experience and knowledge that they're bringing forward. So without further ado, I'd also like to welcome our wonderful panelists. Thank you so much for being a part of this. And I'm just going to do some brief introductions. We have Dr. Tabitha with us, who's a pediatrician, a doctor dedicated to helping children of all ages. She provides comprehensive medical treatment for babies, kids, and adolescents. We have Dr. Mildred Williamson, who served as chief of HIV section for the Illinois Department of Public Health, and most recently, the executive director of CORE. She now serves as the adjunct assistant professor for Community Health Science UI School of Public Health. Kendall Moore, who is a community advocate for the reentry population and also works with AIDS Healthcare Foundation, and also does work with WVON and is a radio personality with them. So does a lot in the community. And then we have the esteemed Reverend Dr. Evelyn Collier-Dixon, who has been in the community, has provided leadership and direction and coordinating for nurse services. She is from the Chicago chapter of the Black Nurses Association, and has done a lot to implement as well as work cooperatively and collaboratively to ensure positive and safe environments for all those for optimal healthcare. So we have a wealth of experience with us to discuss these topics today. And we're really excited to jump into it. So thank you all. Thank you, Reverend Dr. Evelyn Collier-Dixon. Thank you, Dr. Mildred Williamson and Kendall and Dr. Tabitha Watts. We would like to start out, as we're talking about medical mistrust, to ask a question about defining medical mistrust. So there are a number of definitions out there about medical mistrust and what it means. But we would like to ask you all, what is your definition of medical mistrust? And how do you believe it shows up in our communities, in the medicine and research and elsewhere? It's been said that the term medical mistrust in itself is misleading because it puts the onus, mistrust puts the onus on communities, whereas really the onus lies on the medical field, because the mistrust really belongs to the people who've done it, who've let the communities down. So what do you believe is the definition of medical mistrust, and how do you believe it really does show up?
Well, hi, I can start off. I'm Reverend Evelyn, Dr. Evelyn Collier-Dixon, and of course, I am a nurse. So, of course, I've first-handly experienced a lot of medical mistrust. I've heard about it. I've researched it, and there are a lot of things that we can certainly talk about as it relates to medical mistrust. Health research in the United States has helped a lot of lives of millions of people, but health research has not always done the best for some people and some communities, especially those of color. And those of color, and I can certainly speak for that because I am of that color. And we have suffered a lot due to unethical practices, okay? We've studied and we've talked about, and many of us know about the different studies that occurred in years past, especially like the Tuskegee study in Alabama and contraceptive trial study in Puerto Rico, and all of those trials that were done, but they were not done to the benefit of those of color. And they were done with an intent of one thing, but it did not deliver what it was intended to deliver. And so while none of us can wave a magic wand to erase the past. We can't do that, but we can regain trust. And it is our job to be authentic about that trust. And it's our job to be honest. And then as we do that and be honest with our past, because we cannot erase the past, and there's no need of us even trying to do that. But let us be honest and try to move on and better the past as we move forward. So, and there are some ways that we can do that. I'm just going to let the other panelists have their part too. But yes, certainly I have experienced medical mistrust first-handedly. I've heard about medical mistrust. Our people suffer as a result of, we of course are the underserved and unserved population. And then unserved and underserved, it has caused a lot of disenfranchising of us not wanting to participate in certain researches. So, and that's understandable. But like I said, that's the past. What we need to do is focus on now and move on to the future.
Mildred, and first of all, I want to say thank you to those who invited me to participate. I really appreciate being asked to be a part of this. I have absolutely no disagreement with what was previously said. I just would like to add a couple things. It's multifaceted in terms of medical mistrust, and I think one major element obviously is the many atrocities historically and not so, not so far in the past that have been unethical and unacceptable, and they're all documented, and I'm sure there are some that are not. But alongside of that same history is the history of being treated as less than human insofar as access to healthcare at all. And so history is full of stories of the famous and not so famous who died because they were not the right color to be served at XYZ hospital that didn't serve African Americans or other people of color. And even those that might have been served at one or more of these hospitals may not have been given all the best science and knowledge at the time for their treatment when it was available, and still life was lost, or quality of life may have been lost. And while those historical issues are there, and this I would not say is exactly the same today. Today, we still have unequal access to healthcare at all due to economic reasons. And now, insofar as the way in which the Affordable Care Act is utilized, not all states have chosen to expand Medicaid, so that you have this inequality in the face of a major legislative effort that was done in order to improve access to care. But the fact that states could take an individual decision about expanding Medicaid automatically, when some states did not do that, it automatically created an exacerbated situation of poor access. So that's just on a national level and sort of basic, but I just think both of those things are out there. The historical mistreatment in terms of research and how it's been practiced, and the historical denial of humane treatment for healthcare in general. And that's come from many different ways. And we're working with both of those things and the remnants of them right now in the 21st century. And it's in that context that we try to address going forward, just as what was said earlier. But I think the first piece in going forward is acknowledging the complexity and devastating outcomes of these practices over, hundreds of years.
Yeah, and I would absolutely agree with what both of the other panelists, and thank you, by the way, for allowing me to be a part of such a tremendous discussion. I would agree and simply add that as early, the first African-American, the first slaves who were brought to this country, they were practiced upon by doctors who had carte blanche on a population that was enslaved. And it probably goes further back than that, but I'll start there as a baseline and a premise as to why there is an enormous amount of distrust among, particularly with Blacks, when it comes to them receiving health care. As alluded to previously, we discussed the Tuskegee experiment quite often, but there are tons of other studies that have been done to the Black population that really it has caused, and it continues to cause, havoc within our populations and subpopulations. There is. I start there because just sitting here listening to the conversation, the COVID crisis right now is really showing how huge of a distrust it is and how underserved the Black communities are when it comes to the medical field. It was 40 years ago when we really start paying attention to it from a medical standpoint. But even with today's vaccination rates, or lack thereof in the African-American community in particular, folks either don't want to take it because they don't trust the science, or they don't have access to it. And that in and of itself, I think, kind of sums up where we are as a country, specifically, as it relates to healthcare among Blacks. It's a great conversation, and I'm looking very forward to continuing
it. And you bring up a great point too, and moving into speaking about COVID and the research piece, because when it came to the research for COVID, there was so little participation amongst our communities. I think it was as low as, so we're 13%, 15% of the population. I think it was 10% for Pfizer. Yes, 10% for Pfizer. So it begs to question, we know about, I won't say we all, but many people know about Tuskegee. And we talk about these different things from the past, but how do we address the current concerns and fears? How do researchers really get at that? Because we know the impact that it has today. So how do we mend it? I hear a lot of what you all are saying, and I heard you, Dr. Williamson, when you said, acknowledging it. And I do hear different places, and I see the commercials and things like that where folks are trying to acknowledge the harms of the past. But where do we really get to what the things are for today? What the needs are for our communities today? What are your thoughts?
Well, I definitely, hi, I'm Dr. Watts. So glad to be here. And could probably let me know if I'm too long-winded, because I'll talk about things forever. I would start at least from the research piece, and I'll go back to my thoughts about the medical mistrust. But I mean that, that thread weaves through all of this is outside, from my own experience, I feel like outside the medical space, research is still a 4-letter word, right? In communities of color, due to these historical and very current realities of the relationship of people of color and information, right? And when we go to that medical mistrust piece, and yes, we probably do need to find better wording, because oftentimes we think about mistrust as an episodic or an individual thing. We don't trust this doctor, we don't trust this medicine, but it's apprehension as it relates to your care, right? Apprehension of the quality and the intent behind your care. And everything is your care, right? There, whether it's mental health care, whether it's your diabetes care, whether it's, you know, your cold, having an upper respiratory infection, or care of your loved ones, that is overall going to be a reflection of, are you cared for, right? And do the people that are in these roles, and whether it's the front-facing physician or nurse, or is it the pharmacist who packages your medication, or the pharmaceutical company that produces your medication, or the insurance company that's supposed to pay for your medication? There are so many steps where there's an opportunity, or where mistrust is there, because there is a lack of you know, true appreciation that all of the parties involved truly care about your well-being. And in terms of how, as researchers, how do we address that? I definitely agree. The conversation has to happen, and I feel that everyone needs to be comfortable with that conversation. It can be an uncomfortable conversation, but everyone involved has to be comfortable with addressing it in a very, you know, basic as well as a very high level conversation, because it is the elephant in the room, and it is in every room that we are part of.
Can I just say that, Dr. Watts, you're absolutely right. And I want to thank you all, too, for allowing me to be a part of this prestigious panel. Thank you so kindly. I've been apprehensive about it, and now it's here. So thank you so kindly. But I just want to say, just kind of piggyback on what Dr. Watts said about the comfortable level. As nurses, that's basically where most are comfortable. That's where it starts with us. You know, so it has been a cliche that I'm going to ask my nurse, because my doctor, I'm afraid to. That comfort level has not been there. You know, they've been like placed in a position of, well, I'm afraid to ask. And so it comes back to the nurse. And I guess the reason why it comes back to the nurse is because we're there for 24 hours for the most part. And we become advocates. We become family to them. You know, the medical staff come in and they, you know, do what they have to do, and we appreciate that, but they leave. But we're there. So that comfort level is developed there. So the National Black Nurses Association, we have committed to serving all the population, regardless to race, creed, color, whatever the diversity is, whatever. We are committed to teaching and to giving this information to them, because we know that we truly are on the front line. We are frontliners when it comes to providing the care, and we are frontliners when it comes to disseminating the information. So the comfort level we're trying to work at, and that's where we're trying to build the trust with the community, with our clients, so that they can develop that. And then once they develop the trust with us, then they'll feel more comfortable in participating in whatever it is, the research and the vaccines, or whatever the case might be. So we're committed to, of course, doing that. And we, of course, are culturally competent, and we believe in diversity. We have professional nurses, we have student nurses, we have all kinds of level of nurses where we can really reach the population.
You know, it's interesting that you bring that up, Dr. Reverend Collier-Dixon, because there is information out there that says, or there's several studies out there that say many non-white patients prefer healthcare practitioners who share their racial identity. So as a Black nurse, you know, you may kind of relate to this. So they feel their overall medical care is more, you know, is improved, is taken care of, is being heard. So patients in these studies often, you know, cited improved communication, respectful treatment, increased availability as reasons for seeing providers of same racial identity as something that they would appreciate. So I guess I would ask, could more Black physicians, researchers, or BIPOC physicians and researchers, could that be a real solution? And how, if so, then how do we support that? Or, you know, do we continue to improve the training and the training and the things that we do now to just overall blanket improve the training of empathy and respect and communication of all providers?
I would like to say a couple things on that. One is this is one of those areas where we need some progress. So, very close friend of mine who's a retired physician, African-American woman, who graduated from medical school in 1978, often shares with me that there are fewer African-American male physicians graduating in medical school today than there were when she graduated in 1978. And what that says to me is that many things, but one is we must look at our K through 12 basic education, beginning of that pipeline, to grow the number of people going into, again, not just training for MDs, but all of the health professions, including researchers of all types. So that is a major area of concern insofar as really being able to be robust about addressing, improving the diversity of medical providers of all types in our healthcare system. At the same time, too, for those medical providers, researchers, innovators who are people of color, there's too little attention paid to them and their accomplishments. So, so for example, yes, it's true that the percentage of people of color, I think in the Pfizer clinical trial that you talked about is small. But I know, insofar as Cook County is concerned, I know we had the highest percentage of diverse participants in the study at all. Our patient population has been participants in all of the COVID studies that have been made available here, including the early treatment studies that were developed in the hospitalized patient population, and then on to the vaccine studies. And the overwhelming majority of participants in those studies from our health system were people of color. So again, is that enough? I'm not going to say that, but the activities of the researchers, the medical providers, the innovators within that system need to be known, need to have credit, just like the African-American woman who participated in the development of the Moderna vaccine. Most people don't know about that. The more those kinds of things get shared, two things, it seems to me, can happen. One is it may help in terms of moving forward in building trust, but it also may help in inspiring other young people of color to say, hey, maybe this is a career I could do because somebody who looks like me is doing it. So those things need to also be on the table at this time, insofar as in that equation about moving forward.
I just want to jump in. I appreciate that, Dr. Williamson. I just want to jump in and clarify too. So many of your research medical providers and things like that who pulled in a lot of diverse participants, were many of them BIPOC?
Yes.
Yeah. Okay, just want to pull that
Yeah,
out.
just like, for example, many of you may be familiar with the studies that proved PrEP to be effective for young people. Our researchers, our medical providers were involved in those studies that proved that to be effective. Now, are all of our providers people of color? Absolutely not. But there are those among them who were key leaders in those protocols. And I feel like that needs to be shared. And I'm sure at other institutions there are some. Is it enough? Absolutely not. But those who are there, they need to be recognized.
Jolie, if I may, I would add, and that's great information, from a community-based standpoint, when it comes to research and studies, and I know I may be preaching to the choir right now, many of African-American Blacks participate because they need the money. And if there is no money, in many of the instances, they're not donating their time and their body for the sake of. That's number one. And that in and of itself, we really should have when I say we, I'm referring to the medical community, should take a very hard look at that. Because many of the participants, when it comes to the African-American community, are targeted for that exact reason. And I akin it to doctors during slavery having absolute control to do whatever they wanted to do because the slaves didn't have a choice. As far as how do we proceed and move forward? And I know it's the elephant in the room, and we try our best to be politically correct when we are among people outside of our race. But when we are having internal conversations, the bigger conversation is the systemic racism. So when we talk about K through 12, the part of the conversation should also be, what is the education system like in those communities of color? Are those communities of color in those school systems better preparing those students and those families to produce doctors, to produce researchers, et cetera, et cetera? And when there needs to be a stronger focus on the totality of our young Black students when it comes to science. The kids are failing, many of them are failing miserably. And I'm talking about currently due to COVID and et cetera. And, I don't want to go on and on and on. By the time they get out of high school, we can look for the past 5 years, how many are going to college, even coming out of high school? How many are being put, in a queue to become part of the science community? And so when we get the drop in the bucket of this brilliant young Black male or female scientists, they are to be celebrated. I would add, simultaneously, systemically, we should be addressing the very things that we're talking about on the front end.
And I thank you for that, Mr. Moore. And I would add, not only are they to be celebrated, I would challenge that we normalize it, right? That we go from, of course, because you don't want to minimize. It is great. It is wonderful. And this is also what we do. Oftentimes, if of course, people, oh my gosh, you're a Black doctor, or you're a doctor. And depending on who's saying it to me, you can see the surprise and what I, personally, not this is all about me, but what I've adopted is going, hey, in my world, there are plenty of Black doctors. There are plenty of Black nurses. There are plenty of Black researchers. There are plenty of Black PhDs. You need to get out more. It's really kind of the thought. And so I would say that same thing as we talk about K through 12 or STEM and STEAM and introducing that to our children and, our young adults, is that normalizing science, normalizing math, science. And even though a lot of us are like, intimidated by math, like, oh, math is so hard. We do math every day, even if we're not doing advanced math, we're doing math every day. And so to just kind of normalize those things, definitely in addition to celebrating it or on top of celebrating it. But I do think the answer is definitely more. More is definitely part of that answer, right? More researchers, more medical students of color, more, healthcare workers of color definitely helps, because we need to be in these spaces and at all levels. It is not just enough to have Black nurses. It's not just enough to have Black doctors. We need Black chairs, right, of departments. We need Black, CEOs of hospital, of color. We need to, have people of color at the head of the pharmaceutical, industry and of these major corporations, because just having, people of color only at the front facing or at the, I guess it's not, I guess at an entry level of that means that you're only involved in so many conversations, right? And we need to be in those spaces that we are involved in those conversations at every level.
Absolutely concur.
Right. Can I just say real briefly, and I like that about the K through 12. That's where we really should start. But if we think about it, we have missed a generation, and those children that are K through 12 have parents, and they're somewhere in their late 20s, early 30s. If we could refocus and try to capture some of them who are in that missed generation, put them back into the system, because right now they're like counted out for the most part. They just feel like, we're a lost generation and nobody cares. I think we need to refocus and try to reach that population. Sometimes when you get in your early 30s, mid 30s, you think that you're too old to pursue, but you really are not. Sometimes it's the best time to start because you're really serious about it, right, Dr. Watts? So I think that we need to capture and try to reach that generation that has been missed.
I appreciate that, and I can see that. We had a speaker at the beginning. We had a keynote, Yazir Henry. And earlier this week, he was talking about the concept of intergenerational injury and trauma. And so as you're talking about, this group that has been missed and recapturing them, it kind of makes me think about that, him speaking about the injury and trauma that has been carried through, going all the way back to, when Kendall took us all the way back to the pain of, this has been happening since coming over on slave ships. We're talking about Tuskegee, but we've been, our bodies have been used without any thought. Those things have been happening for a long time. So thinking about the experiences of our ancestors and how it's impacted our perspectives and our attitudes and our beliefs. And so I guess I'm thinking about, I'm pulling it together with what you're saying, Dr. Evelyn, and wondering how we pull that generation in and bring it into also the economic relief, because there is a piece that I feel like it comes together too. Like, how do we pull that generation in? How do we address the injury of years and years and years of, you know, this intergenerational hurt, and then also really boil it down to practical things that we can do. Like Kendall said, like, you're not going to get folks without bringing in some money, you know, and we know, we've all been a part of research. We know that that dollar amount comes into it. And at the same time, I happen to be one of those people, like, you can give a person a fish or you can teach them how to fish. And that's what I hear Dr. Evelyn say. Like, how do we pull this generation in and remind them that it's not too late to maybe get a position in here or do something like that, get a job in this field. But I wonder, what's the practical way to do that? You all are nurses, doctors, you're in the community. Kendall, how do you actually do that? How do you pull folks from the intergenerational pain and then say, it's not too late, you can do this? What does that look like?
Immediately, I would add mentorship, and mentorship, scholarship, and comprehensive education. The focus right now, to me, it's always been this way, but I think that we have, when I say we, I'm talking about the Black community. This is a time in history that I think that we really can push the reset button and in better positions, better our position as a culture in society. But again, specifically, mentorship, groups, your fraternities and your sororities, folks who are on the cusp or can immediately reach back over the wall for the generation, quote unquote, that kind of has been lost. Those late 20, early 30 folks. And those really are some very tangible things that can happen. Everyone sitting on this panel, and many of you who are listening and participating while you're listening, I would humbly, challenge everyone. Each one teach one. And it's going to take time, and it will take sacrifice. Especially, everyone has jobs, or if you don't, you're doing something that consumes your time. But we have to deliberately reach out to those schools, to those individuals, to those groups, and put forth effort in what it is that is trying to get accomplished. Other than that, we're just talking heads. We can rattle on. I'm sorry.
I'm so sorry to interrupt you. I'm sorry.
No.
I'd just like to add to that. I've had the great fortune to work with students from high school to graduate school, just about everywhere I've worked. I've worked with students who, when I first worked with them, they were in high school and they have their doctorate degrees today. I feel like that is something we all can do in our professional sphere. But I would also add that we should have direct connections with the schools around us, the elementary and high schools that are in proximity to our places of work. And, not necessarily next door, but, make a connection with those schools and whatever programs they have. I think to make a difference, we have to do the reach out. I also think for those engaged in NIH research, there's a wonderful feature in the NIH research apparatus that allows for you to take on students from high school all the way to graduate school in terms of the internship scientific experience that a young person can get working under the tutelage of the principal investigators of these studies. And that should be much more deliberate and much more regular in practice. So there are mechanisms that can be better utilized or more broadly utilized if we're willing to be intentional about it, take it seriously, and do the proper outreach that we need to the communities that are all around us. You know, very often our major academic medical centers are, I know the one that I attended is sitting surrounded on three sides by disenfranchised communities. On the fourth side is Lake Michigan. I mean, so now you know I went to the University of Chicago. So all I'm saying is we need to do a better job of being deliberate about this level of inclusion, as young of a level as we can handle in our places of professional work.
One thing that I wanted, thank you, Dr. Williamson, and I guess, I don't know if it's a question or a statement, but I am a clinician who's dabbled in research and has a lot more interest in research, but I found that there's the clinical side, they're the clinical people, and they're the research people. And I'll speak for the more clinical people. We can be very intimidated by you research people. You're like, I don't know the first thing. What's the difference between a case report and a literature search, and who's going to take it? How do I publish it and put it in a journal? And so, at least in my perspective, that just may be me. But one thing that I think that could be helpful is somehow there's a bridge between these two sides. How can you draw in more clinical people? There's politics in everything, right? And so there's definitely politics in the research arm that a lot of us clinical people just don't know. And so I think that is another way, because when we look at where we tend to see a lot of our providers of color, I mean, I could totally be wrong, but I would guess that we see a lot more on the clinical side and not involved in research as much as we need us to be. And so that, I think, is also something that's necessary, is, you know, some of these better conversations, instead of, sometimes I just feel siloed that, yeah, we're the clinician, those are the research people. You know, call them when you want the interesting research stuff, or you're trying to get a patient, you know, enroll a patient for their study, and then that's it. So that's just something I would offer that maybe we could do also.
Well, it's interesting that Dr. Watts brought up about the research, and that kind of segues into my purpose here today with the All of Us Research program that the Black nurses have been have collaborated with to ensure that, and I'm sure most of you have heard about it, but my responsibility is to talk a little bit about it, the All of Us Research program, and it's helping to build a diverse group of people, bringing all kinds of people, and we're trying to reach at least 1 million people across the United States, and we're trying to provide information for them, because all of us believes that that we're each an individual. We're not a group of people. You know, most studies have been a group of people, but all of us look at one person at a time. There's no cookie cutter for, you know, that fits one size fit all with All of Us Research program. Okay. And then, of course, that mistrust that we talked about earlier on, that doesn't happen with the All of Us Research program, because your information is handled as your information and it is private to you. So I'm just saying that the All of Us Research program, which is a part of NIH, is an excellent program. And you and Dr. Watts, as a clinician, we would ask if you would talk to your clients, and Dr. Williamson and Mr. Moore and all on the panel about the research project. And we will certainly at the end of this presentation tell you how you can tap into it, because the All of Us Research program is really on the move, and we're trying to reach 1 million people, and we have we've reached quite a few. And most of the participants have been very satisfied because they can retrieve their own information. where whatever information is taken from them is in a data bank and it's unique to them, and no one has access to that information but them. So we'll give you the site to go to at the end of this presentation.
Thank you. Thank you. And I want to leave time to address some of the comments in there, but I do want to bring up something that Dr. Evelyn Collier-Dixon brought up, which is really, and Dr. Watts was going there, this where everything meets, because precision medicine or genetics, I mean, this is where everything is coming together. And there's a lot of talk about, genetic testing and precision medicine being this wave of the future. And either it's going to help with racial equity, or it's going to cause a greater divide. And so, as you're talking, Dr. Watts, about clinical and how do we build these bridges between research and clinical, because, and right now, if there's any time that is needed, it's now, right? Because what researchers are doing is really going to impact clinical if precision medicine is the direction that we're going, and it could be impacting how clinicians are either building bridges with their patients or leaving more patients behind. And Kendall is a representative of the community, as you're talking about, being intentional and not being a talking head. This is where everyone comes together, nurses, doctors, providers, researchers, and everyone. So this is where everything meets, for sure. So, and this is, and it's not often that in this space too, you all have brought up a lot of the socioeconomic piece too. Genetic testing and other research places don't often pull out socioeconomic piece. They may say check off for Black and white, but they don't talk about the risks that also are involved in where a person lives. So you have an opportunity too to be vocal about that and collecting and talking about those disparities. I know there's only 10 minutes left. If anyone has anything to say about that, I want to give opportunity for you all to respond. But I also want to allow for there's a lot of comments in here too. So I want to get some of these comments. Someone asked about the point earlier on medical mistrust. Is a more accurate term medical system failure versus medical mistrust?
It's a medical system failure, definitely, or racism in medicine, racism in everything, right? I think that there was some article I read some time ago about, it's like, it was 75, but now it's gone to 103 things that white people or people who are not of color can do to help with equity. And one of the things listed, it was, don't ask, is this racist? Whatever the situation that you're assessing, it is ask how much racism plays a role in this, or how much of this response is due to racism. And that way, it allows you to kind of pull out or focus on what the problem is. How does racism, systemic racism, influence the assessment of the situation, and then how to kind of address it going from that person, going from that point forward. And so, I would, kind of propose that is definitely asking, I don't know, medical system failure, or just, how much of whatever this issue is due to racism, or how much of a role does racism play in that issue?
Right. And we have to keep it real. It may be termed medical system failure now, but it all resolves back to its medical mistrust. That's what it was. That's what it is. we can call it whatever we want. It still is medical mistrust that's very prevalent among people of color.
This next one is, thank you. This next one is something that we had actually discussed. So I'm going to ask if you all would like to respond. Are any of you all willing to share your own experience or level of mistrust or perhaps trust in the medical system as an example to help others? So we had talked maybe about your own experience that had impacted you with either a medical professional or research experience or with a patient that you all might be willing to share.
Sure, I'll go because mine is actually pretty recent. I have a 20-month-old, and some months ago, she had this perceived bellyache, and I'm a PDR doc. This is kind of what I do. And she had a bellyache, so I took her to the emergency department, not at my home institution, but where most of her care, where she gets her care, and she had an abdominal ultrasound, and we thought it was an intussusception. It was not. It turned out, so it wasn't that. But an incidental finding was that she had gallstones. Now, we don't see a lot of pediatric gallstones, especially in toddlers. It's very interesting. And so it was kind of like, oh, no intussusception, but by the way, she has gallstones. She should follow up with a pediatric surgeon for that. Sure. So I'm looking through the panel to try and find a pediatric surgeon of color. And I found one, and I was like, oh my gosh, this is super awesome. So I had been trying to call and make an appointment with that pediatric surgeon, and the receptionist was always like, well, we don't have anybody on our list with that name. Maybe it's a resident. And I was like, no, it has, her residency, her fellowship, she's an attending. Why is this not listed? And so I felt like, okay, why are they purposely not trying to give this Black female surgeon a patient? This is ridiculous. And I spoke with my daughter's pediatrician about it. And so he said he was going to try. And he was like, yeah, I got the same result. And so I actually stopped at that point. Of course, I did my own literature search. It was like, oh, most pediatric gallstones will self-resolve. And so, if there's not giving them a problem, don't worry about it. And so I did not pursue it further. Fast forward to about 2 weeks ago, my daughter started having, this abdominal pain and some acolic stools. And so ultimately she ended up having a gallstone stuck in her common bile duct. So we go back to that institution. We get the pediatric surgeon who was on call, which was not a Black female. And overall, my daughter's fine. She had surgery and everything's great. But now in retrospect, right? Maybe not having this just looked at and surveyed by a surgeon earlier, maybe we would have gone to surgery sooner, right? Maybe she would have had an elective cholecystectomy sooner. So I am, and I'm pretty much, I'm comfortable with talking. I'm comfortable with advocating for myself and my children, and this is what I do. And yet, and still, there's some level of medical mistrust that I felt that, I don't know why they were lying about this doctor. It turns out she is part of the group, but she sees patients at a completely different location. And, there's just all these other affiliations, so I couldn't see her at that site. But that is just kind of wanted to share that. You can have all the information, you can have all of the, resources, and yet it will still affect, how things are perceived.
Thank you. Thank you for sharing. I appreciate that. So another one that came up was, do you think representation in the system does equal change in the system?
Of course it does. I think representation in the system definitely affects the change, because if you're at the table, then you have a voice. But if you're not at the table and you have no representation, then you don't have a voice. So that's why we push that African Americans or people of color are at the medical table making decisions, and of course, sharing what like we're sharing today, because how else will one know unless we let them know? You have to be there in order to let them know, because perception can be everything is okay. when everything is really not okay. And they won't know that unless we're there to represent for ourselves. So that's why I say it's very critically important that we not only be part of this group, but we need to be at the table so that we can make our concerns known.
I would just want to add one other thing to that. I absolutely agree. But that plus patient or client voice is really critical in terms of making sure that, let's put it this way, in terms of making sure about accountability. I think the combined message and input of a diverse, workforce, as well as the open and welcomed input from your patient or client population is critical.
I'm gonna ask this one last, maybe because we only have a couple minutes left. They said, I don't think this was asked already. I don't know if this is asked already, but with the mentorship in the public health medical fields and participating in panels like this, while also mentoring and just generally existing as BIPOC people, where is the rest for professionals? We are often experiencing double what our white counterparts are experiencing regarding secondhand trauma of our clients with less resources and if we decide to work in our own neighborhoods. So where is the rest? How do you all take care of yourselves? How do you all?
I am a fan of the spa. So I am a huge advocate for wellness, especially physician wellness, because we tend to want to take care of everybody before we take care of ourselves, as a given. And I mean, not just for physicians, but just, because it's one of the spaces I'm in. And I think it's really important for us to accept that, we're not super people. We're not meant to be. Make sure we prioritize self-care and whatever that looks like. Make sure it works for you, not necessarily what everyone else thinks that's supposed to look like. If running on the lakefront is relaxing to you, run on the lakefront. My mom was like, exercise, how can it be relaxing? But but you have to do what works for you.
I'm trying to learn how to spell rest. I don't know how to even, and can't pronounce it because it's just not in my vocabulary. But at some point in time, the body will tell you when you need rest. So that's what I'm not relying on the fact for my body to tell me. I'm going to learn how to rest and learn how to say no, because at the end of the day, I have to take care of me before I can take care of someone else. But thanks for that question. That was a real good question.
It was.
Thank you. And thank you all for joining us. Thank you so much to our panelists. Thank you so much, Dr. Evelyn Collier-Dixon, Dr. Mildred Williamson, Mr. Kendall Moore, and Dr. Tabitha Watts. You all have been amazing. And thank you to all those who joined today. We really appreciate what a great wrap up to the week. So thank you, thank you, thank you.
Thank you all for your attention.
Thank you for including.
Can I just say before we conclude that, thank you, yes, and thank you. And if you're interested in the All of Us Research Project, just go to our website at joinallofus.org, joinallofus.org, and I guarantee you that we are fair and equitable across the board. Thank you.
Right. And we do have the presentation coming up after this. If you'd like to hang on, Ross Bayers will be presenting in just a moment if you'd like to stay on for that.
I'm just going to do the switch over to the tech for the other presentation. All right. Can I get a thumbs up that we can see the slides? Beautiful. Okay. First of all, thank you so much to the panel. I've been on the committee to help plan this, and it's a really beautiful thing to see this panel come to fruition with such a large crowd to see it. I think this is such a conversation that has been needed to be had for quite some time now. And it's just lovely to hear different perspectives from many different areas of healthcare. And that was the point of our conversation. So I am here with the All of Us Research Program, and our focus this week has been on DNA, and I want to talk specifically to the aspect of DNA in the All of Us Research Program. And so just as an intro, my name is Ross Byers. I am with the Illinois Precision Medicine Consortium, which is the All of Us Research Program for the entire state of Illinois. I specifically work at Northwestern University. However, I am here today to represent the entire All of Us Illinois and on the challenge, the changing the future of health and the power of DNA. And so what is the All of Us Research Program? I think Reverend Dr. Evelyn Collier-Dixon has given us a wonderful, amazing intro to what the program is. So this slide you all already kind of know. So it's really just, we have a simple mission to speed up research and health breakthroughs. And so we're asking 1 million people nationwide to share this. And then all of that information can then later be used to conduct thousands of health studies at a very rapid rate that has never before been the case. And so, like I mentioned, the All of Us Precision Illinois Precision Medicine Consortium. This is made up of Northwestern, Rush, North Shore, University of Chicago, and UIC. And like I said, I work with the Northwestern in my day-to-day, but I'm here for All of Us Illinois today. So here's some kind of questions that all of us can help us answer. So how can we develop better pain medications that aren't addictive? We talk about opioids all the time, and the research is working on it, but we need to get it and understand at a population level and for different populations. Can we develop cancer cures that work the first time so that we don't have this trial and error of chemotherapy? And also, how can we reduce health disparities and inequities in a way that is actually sustainable and that will stay over time? And so All of Us Research Program is different than most research. So many research studies focus specifically on one disease or one issue in one population. This is going to serve as a national resource to inform thousands of studies on a variety of different health conditions. And so the goal is really to enroll 1 million people and for it to be one of the largest health databases of its kind. And so as that database grows, we can see patterns that we haven't been able to see before, and those can really influence the way in which we approach medicine and health. And through that, one of our largest goals is on diversity, that we want to engage a community of participants that really reflects the nation, not just the people who have easy access to research or the people who have previously been in research. We want people who have previously not been represented in research to especially be a part of the program. And we welcome people from all backgrounds, healthy or sick. Some studies don't allow that, but we are not that. And then lastly, we see our participants as partners. We have sought participant input at any and every aspect of the program, and we're committed to transparency. It's actually one of our core values. So if we are transparent and we're honest, we build trust. And that is how we counteract medical mistrust. And a one-size-fits-all type of approach to medicine, that is not taking into account everyone. And that's where we're at currently, and we're trying to work away from. So a value for participating, there's a lot of value for it, but especially the chance to learn about your own health and maybe your own personal risk factors, to understand disease, improve the health of future generations, and then also to ensure that your community is heard. And that is something that many of us are really passionate about. We want our community to be heard, but not many communities have been heard. And so this is really a chance to also learn about additional research opportunities that can also help you, your community, and the greater nation. And we really value the idea of a diverse data set, because if the data set is not diverse, we're not representing everyone. And that's how we've gotten to the point where we're at now. And so if we explore these genomic data, and I'll get further into what that really looks like soon, we're going to take into context other facts that before have been left out of the puzzle. And so we're talking about DNA, so I want to do just a quick basics of DNA. So DNA, deoxyribonucleic acid, it is essentially the material that makes up all of your genes. And your genes, we can think of those almost like recipes for making proteins in your body. And those proteins, they determine a lot about you, your hair color, your eye color, whether you have risk for certain diseases or not. And these pass from parents to kids. So half of your DNA comes from your biological mother and the other half comes from your biological father. And the one interesting thing is that more than 99% of our DNA is all the same among all humans. And it's that one little 1% that makes each of us unique. And it's that 1% that we really are wanting to learn about. And genes, they absolutely affect our health, and it affects disease. Our bodies are complex. There's a lot of teamwork among different molecules in the body. And proteins are one of those that's really everywhere in the body. And so if that recipe is altered in that gene, it may affect your health and it may cause disease. And so I've been using the terms genomics and genetics, and I want to do a little deep dive what the difference is, because we hear these things, but they're actually different. So when we look at genetics and genes, really that's where people are looking at what's passed down in your family. And when we think about this, the way that we talk about this, it's like if you were studying the career of one player on a team. So it's that one gene that's doing that thing. Whereas when we look at genomics, that's looking at all of your genes. That's the team. That's also the coach, the university that they're playing for, all of the factors that come together to make you, and also the other factors like the environment where you live. And then one other piece to touch on is what is a genetic variant. So a genetic variant, these are the differences in your DNA. That's that 1% where there's variation among humans. And the fact of the matter is most of it is harmless. You think of things like dimples, whether you have them or not, that's genetic. Whether your eyes are brown or blue, your hair texture, your hair color, these are things that come from genetics. However, there are also some that do cause a health problem or maybe increase your chances of that. That's called a pathogenic or capable of causing disease change. And so for all of us, we call genetic variants DNA changes because it's a change in your DNA. And then the topic of the week, so genetic testing. So there's also a little bit here to define. So when we normally are talking about genetic testing and thinking about genetic testing, we're actually talking about recreational genetic testing. So that's your 23andMe, your Ancestry.com. Those are direct-to-consumer genetic tests, and these are not the same as the ones that your doctor or health provider would use. So that is what a true genetic medical test is. That's something that your health provider can use to screen you and diagnose you. But the recreational genetic testing, that's not something that you can do that with. And I like to provide the caveat here that the All of Us research program is just that, a research program. So we do not provide medical tests, medical treatment, or diagnosis. However, we do DNA analysis and we'll provide information back to you about your DNA. And that's something that you can bring to your doctor to further conversations and maybe then do additional testing with your doctor. And we'll talk a bit more about what that looks like later in the presentation. And so what can researchers learn from DNA? So much. So it can identify what makes people more or less likely to develop a disease. It can identify which treatments work best for different groups of people. And it can actually work to a future where we create medications that treat or prevent common conditions in a way that is sensitive to someone's genetic background. And I've linked here, and these slides will be shared. I've linked here on multiple different resources to kind of learn more about DNA. I love DNA. I've always been obsessed about it and fascinated by it. But these are some really great resources to read about. And so with the All of Us research program, we will be returning genetic information to our participants. So what does that look like? So a couple distinctions. The All of Us research program is a research program by the National Institute of Health. That means we are protected in a lot of ways, and you will never have to pay for your genetic results as a part of the program. They are entirely free to you, and we'll analyze that DNA using different methods, which I'll also talk about a little bit later, of genotyping or whole genome sequencing. And we're never going to sell your DNA information or make money off of it. And that cannot be said the same for direct-to-consumer testing. And we offer this as a benefit of participating, but it will take time. We already have over 300,000 people who have provided their samples to us. So we're processing a lot of samples at the current time. So we do not provide medical genetic testing. Ours is specifically research testing, as I touched on earlier. And that's really more to learn about genes, how, like, what genetic conditions may be present and what may show up. And research testing, again, cannot be used to make healthcare decisions. Whereas there is clinical testing, and that's what your doctor would do if something were to come up in the DNA report that comes back to you as a part of all of us. And if you do receive health-related DNA results from all of us, they're not a diagnosis, but you can speak with your healthcare provider. And if you do not have a healthcare provider, we actually have something called the Genetic Counseling Resource, and that will connect you with one. And so how will we be analyzing this DNA? So we have 3 genome centers across the country, and they're all syncing up so that they work the exact same way so that we can really process a lot of people, because we're going to have more than 1 million people by the end of this. And so the 2 ways that we're analyzing the DNA are, one, by genotyping, and that looks at a small amount of DNA that gives us information on many of the common changes that are among us, whereas this whole genome sequence is going to look at the whole team. You're going to have all of those genes looked at, and that's an incredibly expensive test if you were to have your genome sequenced outside of the program. Once again, that will be provided to you free of charge. And we do pull from blood samples. So a blood sample will give us the most information about your DNA. And so above this, a blood draw is a standard part of our research protocols. So what kind of information will you get back? So this is the really fun part. This is the part where you get to see some new things. So this is divided into 2 sections. So the first section is ancestry and non-health related traits. And so your ancestry, where your family comes from, and your traits, such as why you might love or hate cilantro. So on that specific point, I'm actually a participant in the program, and I have received my results back so far. And I have always hated cilantro with a passion. Like, even though all my favorite cuisines love to use cilantro, I have a gene that predisposes me to dislike cilantro. And now I can know that about myself, and it's just a nice thing to know. But that's not something like that's going to be something I take to my doctor and be like, so what are we going to do about this, doc? It's just, I'm going to ask for no cilantro. Whereas on the right side of things here, we have things that are medically actionable. So whether you may have an increased risk of developing a particular health condition, how your body might react to certain medications. Our bodies don't all react the same to medicines. But as of right now, with the one-size-fits-all approach, if you have high blood pressure, you're going to get the same medicine no matter who you are. And so that's called pharmacogenetics. And there will be also other health-related information. As we do this, new methods are coming out all the time, and new ways of looking at DNA are happening. And so in the time that we are doing this program, technology is going to come out that does not even exist yet. And so we will always be telling you more about your DNA over time. And I do want to, again, touch on the fact that it's going to take some time to get your DNA results. So how I like to say it is, you'll receive your results on an individualized timeline. It may take anywhere from months to years. And it really just kind of depends on the way that your consents in your samples. It's a kind of a back end type of thing. How to get your DNA results from this program is all the steps of how to take part of the program. So the very first one is creating that participant account and completing the consent to join the program. This is a general consent form, basically telling you what is it that the program is and am I okay with that? And then we also ask you to share your electronic health record with the All of Us research program. And this provides us a much better look at your health, because we're seeing new conditions that may pop up in 5 years. You may not have diabetes in 2021, but what about in 2026 when you've already done your visit with us at one point? And so that's what the health record gives us, an ability to look at a person in a more holistic, large scope. And then we have a consent to receive DNA results. And at the end of that consent, you tell us if you want to get your results. So your results, no matter what, will be analyzed for research purposes. You don't have to receive those results if you don't want to. And I'll touch a bit later about really why that is. And there's multiple considerations. And I think our conversation this week in the panel as well as at other events, really highlights why it's so important that you have the choice of what you want to receive. And then we also have this survey called The Basics. It's pretty much your basics about you as a person. And once you complete that, you can then make an appointment to come into the clinic. And so, or the participant center. So we have participant centers at all of our universities. And at the end of this presentation, I do have a link for you to see. Whichever one you want to. Usually we recommend that you go to the health system that you receive the majority of your care at. And then you have your appointment, you provide your samples, and then you just stay up to date with the program, and soon enough, your DNA results will come back to you if you choose to have them. And we're really, really focused on returning these results in a responsible way. And so this type of return of results is unprecedented. All of Us is the very first large research project at a population level to offer health-related DNA results to participants as just a part of being a part of the program. And so we're building something new here, which is really exciting to be a part of. And so we've partnered with a company called Color. It's a health technology company, and they will have the genetic counseling resource. And this is made up of trained healthcare professionals who can help people understand DNA results. And this is for participants who do or do not have some sort of DNA change that puts them at a higher likelihood. Maybe you just want to understand more about why cilantro tastes like soap. You can talk to them about that, and it'll be entirely free. And if you are found to have a positive disease risk, seeing that you do have a higher risk, you will have an appointment with a genetic counselor who will go over the results and what that means for you. And so another question that I often get is, what if I already have DNA tests done? What if I already got my ancestry results back? Why do I need to provide a new sample for you? And the fact of the matter is, we will still need to analyze your DNA using our research protocols. However, in the future, we will be able to look in your electronic health record if you ever have a medical genetic test, that clinical type of testing. That's something that we'll be able to look at. But ultimately, we'd like to collect your sample and do it the way that we standardly do as a program. And the last piece of my presentation that I really want to touch on, so that I can leave us some time to have a bit of a discussion, is how we protect your DNA and your DNA results. And this is such a pertinent part based on our conversation today. And I really want to dig into some of the specifics here so that you can understand it as best as possible. So the very first fact is your DNA information is de-identified, and also most of your information is de-identified and stored in different locations. And any person who is going to be working with the data, so researchers, they do have to sign an agreement that they will not try in any way to identify you. It's actually like against the rules, and they would be kicked out of the system for it. We follow all federal, state, and local laws and regulations for keeping your information safe. We do have certificates of confidentiality from the US government, and this will help us if there's ever a legal request for your information that could identify you. Those certificates of confidentiality can be used to protect against that. And we store information all on protected computers. We have security experts who routinely do testing of our systems, but if there is ever a data breach, the risk of that is low. We will communicate that to you and what it is that you can do as a result of that. And a really important question that I think many of us are curious about when we talk about DNA results is, how likely is it that I will show to have one of those results? So the truth is, only every 2 to 3 out of 100 people have a DNA change that does raise a risk of having a serious health condition. So that's only 2 to 3% of people. So the highest likelihood is that you may not have any that change that. But it's also your right to know if you want to know. And we will tell you if we find anything new over time. So even if at the first point it doesn't say that, but over time we have this new test that came out of 3 more years of advancement, maybe we find something new, and we will let you know when that occurs or if that occurs. And the other question is, will these results affect your children? And the fact of the matter is, DNA is absolutely passed from parents to children. So your information about your DNA does say something about the information about DNA for your children. And so you have the choice to know if you want to see your results, and you also then have the choice if you want to share them with your family. And our genetic counselors at the Genetic Counseling Resource, they can provide a counseling report and also different educational materials that you can share with your family. And also, if you give them permission, they can speak over the phone and discuss those results with you and your family, all free of charge. Always want to point that part out. And they can also connect you with a health provider, as I mentioned earlier. And will getting your results increase your healthcare costs? What I like to say here is it varies. It depends. So we are not medical diagnosis, as I think I've mentioned multiple times. However, if you bring that information to your healthcare provider, they may order additional testing for diagnosis, and that may be billed to you and your insurance. And also, if you have to make changes to your standard healthcare, maybe you need more preventative testing, or you need to implement some sort of lifestyle change, those may cost more than your current care. And that is why some people choose not to know. Some people don't think it's worth the potential extra costs, and some feel that it's entirely worth it because then you have the information, you can do something about it. And at the end of the day, that is your decision. That is your choice. You provide the consent to each and every type of genetic result for that reason. And then one other question that really comes up, and this will be my last slide for today, is, can this affect my health insurance? Because we know it's already outrageously expensive. And there is this law, actually, that's called the Genetic Information Non-Discrimination Act of 2008, which was just commonly referred to as GINA. And this law really states that health insurers can't use your DNA information against you. So your health insurers can't change your coverage, cancel your coverage, raise your costs, your premiums, anything based on your DNA information. It is strictly against the law. And it also will never share your information with your insurance company. And also the Affordable Care Act and the patient protection aspect of it, it also states that health insurers can't use your health information to decide whether you receive coverage. And so that is another layer here that is helping to protect you. And really, we are just, at the core, we're designed to protect the security of your data. And that is of utmost importance. And with that, I will open it up for any questions, and I'll also check the chat. And feel free to come off mute or put it in the chat if you have any questions. I see that Natasha already put the links in there. Thank you so much, Natasha. Jolie asked a question about whether we have needed to notify folks of a data breach since we've existed. And I'm pretty sure no. That's off the top of my head, I could not tell you of one instance of that. And really, it's that we are continually, every single week or two, there's new improvements being placed onto the systems. And we have a very extensive network of security and coding type of individuals who really safeguard us. And I think that's something that I really value as a participant and as someone who spends my days trying to get more people to be a part of the program. Any questions? I'd love to hear them. Or thoughts.
Hi, I just have a quick question.
Yeah.
In terms of what would be I think this is awesome. I'm totally going to sign up.
Yes.
What would be the best way to direct patients or even, loved ones just to the website, or what would be the best way to kind of get them on board?
Yeah. So I think knowing everything you've talked about and knowing that you provide direct care, I think you and I can have an offline conversation about some different resources that we have available for health providers. And we have providers, we have we value providers as champions. We really view you as champions of the program. And honestly, nurses and doctors have some of the best ability to recruit participants because you're having those interactions with people. You're talking about health. It's just a common part of how you speak to people. And so we have some ways for doctors and nurses to do that. But yeah, absolutely. For anyone, direct them to joinallofus.org. We have a specific link here for the Illinois Precision Medicine Consortium. And that has the phone numbers and emails and contact information for all of our 6 different universities that are a part of our consortium. And so we have also in multiple different regions of Illinois. So I know for a fact, like at Northwestern, we have a site out in Geneva at Del Nor Hospital. We have our site downtown in Streeterville, and then we're soon to be also opening up another site in Grace Lake in kind of the northern region. And so that's also the case for many of the universities. So we're really all over the state, and we're so excited to have more people come in. I'm seeing some questions in the chat that I'd love to answer. So the genomic centers, are they open? They are open. They are running samples every single day. So for all of our different samples for backlog, people are signing those consents, they pull that sample and they're getting it tested. And so they're up and running. There's no cost to join the program. And in fact, usually there is a financial gift card that it comes from doing your visit, but that's a little bit further down the road. You have to, do your surveys, your consents, and work with the university or some other whoever's working with the program, like Center in Halsted. And I do want to take a moment right now to kind of address how awesome Center Halsted is in general, but the fact of how Center in Halsted is really an amazing champion for the All of Us research program. And we have champions all over the city and across the state, and frankly, across the entire country. And without our partner organizations, we really could not do the work that we do. And it's a joy to work with our partner organizations. Now we're close, or maybe even a little bit over time, but I was wondering if there's any other questions. And also on that website, there are emails to all of our different sites that you can ask questions to. And I thank you all for coming. And if you have any questions, please feel free to stay on for a bit. I'll be on here.
Ross, this was wonderful and so informative. Yeah,
that's my goal. That's my goal. Let's inform everyone and make the decision that's best for you. That is the core of it all. Make the decision that's best for you.
If folks wanted to reference any of this information about like genome versus genetics or any of this, can this be found anywhere or?
Yeah, so when you go to joinallofus.org, there's absolutely information on there. And then once you become a participant, you will be receiving information in newsletters. You'll be receiving information in your portal. We're also, there's a learning center aspect to our portal it's being built out over time, but we really truly see the value of not only just doing the research work, but helping everyone to understand the research work, because we just had a whole conversation about the ways in which research has not done that, and we're trying to change that.
Partnership. Great, thank you.
Awesome. All right, if there's not any other questions, I will let you all get on with your merry days. I thank you all for coming. I thank you all so much for being a part of Interwoven Histories. This has really been a wonderful process. And so I am excited for future endeavors between all of us and the Center in Halsted and Chicago Chapter National Black Nurses Association. Thank you all so much.